Okay, in this very last unit here, we're going to talk about healthcare reform and more specifically the Affordable Care Act, otherwise known as Obamacare. And we'll talk a little bit about that and maybe what we should be doing in the future. So the Affordable Care Act was passed under President Obama's administration. And when President Trump was elected, the Republicans had always pledged that if they got back in control, that they would repeal it because they didn't like the Affordable Care Act. There were some proposals that were put out in 2017 to there's two different words. One is repeal the Affordable Care Act and then replace it with something else. And so then that was part of the issue because the public was concerned, well, what exactly are you going to replace it with? So we want to see the details of that. So before we lose this, tell us what that is going to be. And so I think that there was some confusion there and they weren't particularly clear about that. And the bottom line was there was not enough support to repeal the Affordable Care Act. There were several Republican senators who, to quote one, said, "I did not come to Washington to hurt people." So they felt like what was being proposed as a replacement was not better than what the Affordable Care Act is. So that's kind of where things were left in 2017. So why do we even need health reform? And so I think we've looked at that in this class. And so if we look at the triple aim of issues of access, quality, and cost, we know the cost is really high, twice that of other industrialized nations. We also know that we have some problems with quality. But the Affordable Care Act was really targeted as an access program and access legislation. And so the number we're going to use for discussion, though different numbers are used in different places, is that prior to the Affordable Care Act, about 50 million Americans did not have health insurance. And so we know that those without health insurance do not seek care in a timely manner and have poor outcomes. And so, in fact, we're seeing this prove to be true in the COVID outbreak as well. So these are some numbers that we've looked at. And so we see that the cost per capita of the amount of money that we spend per capita on healthcare in the United States is skyrocketing. And so we see it just going up, up, and up. And we know that this is twice as much as other industrialized nations. And so the concern was this is no longer affordable, this is no longer sustainable. And I'll tell you where, as an example of how this plays out. Many supplies were manufactured here in the United States. The healthcare costs of the employees to manufacture supplies in the United States was so high that many companies took the jobs overseas. Not only just because of salaries, it was about the healthcare cost. So we have relied on other countries to manufacture many items because they can be produced cheaper in other nations. Well, COVID has exposed that as one of the problems because where are those swabs? Where are those PPEs? Where are the other kinds of supplies? And so those were being made in other countries. And because of problems in other countries, or China would be a perfect example of somebody who manufactured a lot of these things. They needed more for their own COVID outbreak. And so they weren't going to send that stuff over here. And so these are examples of things that are made in other countries because of, in part, the healthcare costs of employees in the United States. And so for the future, we have a question. Can we bring manufacturing back here? Now, one of the things in particular I was kind of concerned with, I have a friend that's retired from the pharmaceutical industry. And I'm like, I'm concerned that if we get these vaccines developed, where are the vaccines going to be made? Because once again, if we have to rely on getting these from other countries, are we going to be at a disadvantage here? And he said that vaccines are made not only in the United States, they're made right here in North Carolina. So that is very good news, that something that we desperately need to try to get our world returned to normal is manufactured right here in the United States. So what was going on? Healthcare costs were spiraling out of control, and the number of uninsured was reaching that 50 million mark. So we're going to talk about covering the uninsured in a minute, but let's talk about this other fact right now. So we know healthcare costs going up, up, up. And so just like with COVID, with costs, what they wanted to do, they didn't think they could reduce healthcare costs, but they wanted to bend the rate of increase. They wanted to bend this cost curve. So it's just a concept. I want you to kind of understand what we're talking about with things in general when we're trying to bend curves. So that was the idea, is that in part we could control costs. That did not happen, all right? So it was not effective in bending the cost curve. Covering the uninsured, that's a different point. So here's kind of, we've seen this slide before of how people are insured in the United States. And so we know most people are getting health insurance through their employer. We've got Medicare, we've got Medicaid. You can also buy individual coverage. And then we get this huge chunk of people that are uninsured. Now, the problem with the individual coverage prior to the Affordable Care Act is an insurance company, they're for-profit companies. Their reason for existing is to make a profit. So they want to exclude people with really serious illnesses, pre-existing conditions. So if you had no insurance, you were a fine 40-year-old person, and then you got cancer, and you're like, oh my gosh, I need to get some health insurance. The insurance companies are like, we're not insuring you unless you were covered under a group plan where you worked. But as an individual, you were excluded. You could not go buy insurance. One of the key points of the Affordable Care Act is insurance companies could no longer discriminate against people with pre-existing conditions. This has been a lifesaver for people that had pre-existing conditions, and it is one of the reasons why many people do not want the Affordable Care Act repealed, because they do not want to go back to that. Now let's think about the math here a little bit though. If you're an insurance company and you could exclude people with very costly health conditions like cancer, heart disease, then you could keep your prices of premiums down. But if you are now mandated to include everyone, well, then you're going to raise your premium amount. You're going to charge everybody more to cover those high-risk people. This is one of the reasons why many people don't like the Affordable Care Act, because they're like, my premiums went up because now I have to pay for those people as well. I'm not getting anything more than I ever had, and I'm paying more for it. So why would I like this? Unless you're someone who thinks of the greater good and serving these other people. Um, so the question is, what kind of system should we have? And at the end of this course, as I said all along, this is where I wanted you to get. The Affordable Care Act would be kind of in the middle here, between these two arrows. Some people want to go back to the free market system, which we know is really a quasi-free market because it doesn't have transparency and we can't be good consumers. Others are like, no, it did not go far enough. I want what we call Medicare for all. I want a nationalized health system. I want a single payer system. And so hopefully throughout this class and the things you've learned, then you've got a little bit of an idea of what do you think? You know, where should we go? And so these would kind of be the choices. Stay where we are, where we're trying to get universal coverage, where everybody can get insured under the Affordable Care Act. Go back to the free market system, move forward to a single payer system. So many people have asked me, is the Affordable Care Act a good thing or a bad thing? My answer is always, it depends on who you are, all right? If you're an insurance company, you're like, you know what, just tell me what the rules are. I'm going to price my product accordingly, and I will do as well as I always did. Individual people, it depends. Who were you? If you were someone that had insurance through work, you never used insurance, now the insurance that you had before is just more expensive. And so you're like, well, I really didn't gain anything on that. But if you were someone with a pre-existing condition, this was godsend, okay? It's like, oh my gosh, I have cancer. I can now protect myself. I don't have to worry about this. I can go on the market and buy a relatively affordable policy, okay? Now, if you're poor people, part of what they tried to do was to put more people on Medicaid. And so for each state to expand their Medicaid program. The initial bill included that. Something like, 13 states filed a lawsuit against the federal government saying, federal government, you cannot tell us that we have to expand our Medicaid program, okay? This is how, read the Constitution, this is how we're set up. And indeed, it went all the way to the Supreme Court, and the Supreme Court said, yeah, states, you're right, the federal government cannot tell you to do this. All right, so this is kind of a concept you need to understand of how our government is different from other governments. We see it happening now with COVID. What things are under the purview of the states? What things are under the purview of the federal government? All right, so expanding Medicaid was an issue there, and we'll look at that in a minute. So as taxpayers, our taxes have been increased some, kind of in sneaky ways that you may not even know. So for example, one of the ways that this was funded was by putting an excise tax on medical supplies and equipment. If you might be too young to realize this, but after that, a lot of medical supplies are used in vets. So everybody's veterinary bills went up too because they're paying this new excise tax on supplies. All right, so if you were healthcare providers, you're like, well, now if everybody gets insured, then that'll be good because then we won't have these people coming into our system that have no means of payment. So once again, just tell us what the rules are and we will try to follow them. Pharma, they initially, there was going to be some price capping on medicines, and pharma convinced President Obama not to do that. And so that part, they agreed that they would voluntarily reduce pharmacy drug costs by 10% over 8 years or something like that. Okay, so that kind of got negotiated. And then government officials, if you are if your voters are more conservative people tend to be against this. If your voters are more progressive or liberal people, they supported it. So once again, the politicians kind of followed the votes. So does the public like the Affordable Care Act? You know, there's so much behind what happened. You know, when they go out and ask the public, they're like, do you like Obamacare? And they're like, no. And they're like, well, do you like the Affordable Care Act? Well, yeah, I think that's pretty good. All right, they're the same thing. Don't be that person, okay? But in general, it's about 50-50. Half people like it, half people don't like it. And so once again, we're at this stalemate of how to move forward because there's such diversity in thinking about this. So what is it? Here are the key provisions of the Affordable Care Act. As it was initially set up, everybody had to be insured. And so you could go on these state exchanges and buy insurance. And you could buy different levels of insurance, and the better the coverage, the more expensive it was. If you did not make that much money, the federal government subsidized the cost of your insurance. So for example, I knew somebody that made $25,000 a year, and their premiums were about $25 a month. Okay, well that's pretty affordable. But I know somebody that made $150,000 a year, and they had to pay the full price tag. And it started out in year one at $900 and some a month. Then it went up to $1,100 a month to buy it. This was platinum, the good coverage. Then it went up to $1,300 a month to buy this insurance. All right. So affordable is relative. But initially, there was what was called the individual mandate. And you either had to buy insurance and be able to prove that you had insurance, or you had to pay a penalty. This penalty was through each year when you did your tax return, you had to show a certificate of coverage, or you had to pay this fine. So $695 a year as a fine does not seem like that much, a penalty to pay. But let's say you're that 100,000 person. Well, you've got to pay 2.5% of your income. So now you have to pay a penalty of $2,500. But once again, think of that as compared to a premium of $1,100 a month. Okay, for just an individual, let alone if you're trying to buy for your whole family. One of the first things that President Trump did when he came in office, through executive action, he could not repeal the individual mandate in the Affordable Care Act, but he did instruct the Internal Revenue Service not to collect any of these fines. All right. So he took the individual mandate part out. And so who would go uninsured? Well, young, healthy people. And so they were like, well, I'm healthy and not much going on with me, so I'm going to take the risk. Well, that kind of undermined the whole program because they needed the healthy people who were not making any claims on their insurance to subsidize the really high claims of the really sick people and the really old people. All right. So we're in this very strange period of it's not repealed, but certain things are undermine it. And so where do we go from there? Now, in addition, employers had to either insure their employees, any employer greater than 50 employees, or pay $2,000 per employee in penalty. This affected a lot of particularly young people because I knew a lot of college students who were working at wherever, and so if they worked full time, then their employer had to insure them. And so their employers cut back on their hours, and they had to have fewer than 30 hours a week. So then they couldn't make as much money. All right, so this is how all of these details affect people's lives in different ways, and they affect different people in different ways. But for example, even here at App State, we have all these adjunct professors, and so they were not given health benefits because they were not full-time employees. But they went in and looked at teaching 4 courses is considered a full-time load, and there were all these adjuncts that were teaching 4 courses a semester, and they said, that's full-time. You have to provide insurance for them now. So this cost $1 million extra for App State to then insure these adjunct professors. All right, the other part on here that we're looking at is Medicaid expansion. So as I said, that part of the way to get universal coverage or everyone insured is to raise the amount of money you could make and still be eligible for Medicaid. Some states expanded, some did not. All right, so this was estimated to cost this much money. In general, when they estimate how much something is going to cost, it really costs about twice as much as they estimated. But here's just some ways that they said that they would get the money to pay for this coverage. So what did hospitals think about it? Well, prior to the Affordable Care Act, hospitals who had a lot of Medicaid patients or uninsured care got some extra money from the federal government to help them cover this charity of free care that they were giving. So the federal government said, all right, we're going to take that away because now everybody's going to be covered. So they took away this payment, but then as we see, not everybody is covered. There were some workforce things in there. They said they were going to throw some money at training, more doctors, etc. This is in there. I've never heard of anybody that got any of this money. So did it work? Here in North Carolina, it worked really well. So North Carolina enrolled a lot of people in the Affordable Care Act. And so they did some things. They were very, very effective in going out and finding people who were uninsured through community care, legal aid, health departments, social services, etc. Explained the program, got people to see what the benefits were, helped them to understand what subsidies they would get. And so North Carolina was one of the best states in actually getting people signed up for the program. There are a lot of different numbers all over on how effective this program was. I think that the easiest way to think of this is there were approximately 50 million uninsured people, and really the best number I really saw was about half of them, or 25 million, got brought into the system through either going through the exchanges or Medicaid expansion, something like that. So we cut the uninsured population rate in half. Now, the other part of that 50 million uninsured also includes undocumented people, and they were not eligible for this program. So how many undocumented people are there in the United States? Estimates range because they're undocumented. We don't really know. But around 11 million people. So of the 50 million people, around 11 million of them are not included in this program. So that of the remaining, 39 million, about 25 million did get covered through this program. Here's just some examples of the uninsured rates once again. And so as you could see, younger people tended to not join in. Now, remember, one of the things that was true is that if you that was part of the program was if you were under the age of 26, you could stay on your parents' insurance. So that brought some young people in. But there's still a lot of fewer young people that are uninsured, but still gaps there. A lot of women went in, so that kind of helped them with their coverage. So one thing I just want to share real quickly here is when we put together these federal programs, and the same is true of what they're trying to do with the small business subsidies, the unemployment insurance things that are going on now. When the government tries to do massive programs, they don't always go to the people that need it or in the way that you think. And so there was an early program in the Obama administration called Cash for Clunkers. And the idea here is that we can improve emissions and reduce emissions by getting old cars that polluted more off the highways. And that was Cash for Clunkers. And so the idea was, we're going to give you a voucher for $4,200, the federal government was, if you got rid of that old clunker and bought a new car. And so a lot of people took advantage of these cars. The interesting thing, though, if you took the entire amount of money they allocated to this program and divided it by the number of cars they got off the road, it was about $24,000 a car. But the individuals were getting vouchers of only $4,200. So where was the other $20,000 going? Okay? So that's the problem when you have these programs, that you've got to have a way to set up oversight, to analyze them. They may, in theory, seem like a good idea, but who is actually getting the money? And if the idea was to cut emissions, and it only cut emissions by 1%, is this really a good way to spend our resources? So some people are concerned that the Affordable Care Act is a cash for clunkers, and that while good in some ways, it's an inefficient way to do it, and so there are better ways. But as we saw, the Republicans always were criticizing the program, said they had a better program, but then when it came time to put up and say, okay, well, what is your better program? The legislature said, no, that's not a better program. So it's not to say that there isn't a better program. It is not to say that the Affordable Care Act doesn't need to be modified. But people are concerned. They don't, in general, want to go back to where we were. So what's next? Is it going to be repealed? Are we going to replace it with what? Are we going to try to go to a single payer system? And so those are some things for you to think about when you show up at the ballot box next fall. For you, what does it mean? In general, they're trying to cut the money that's going to healthcare services. So your job as a practitioner or as a manager will be efficiency. How do you provide effective care in an efficient way as possible to try to reduce cost? That's the world you'll be going into. And so as taxpayers, we care about this too. So, because we are the ones, as we know, that are footing the bill. So the bottom line, everybody needs to be able to do more with less. We really need to look at how it is that we have set up this system and what is driving the cost, who is getting the money, who is getting the resources, how are we spending the money? So back again, what are our problems? Is it really acute care disease or is it pandemics? Because we've learned that we were not as set up effectively as we needed to be to deal with pandemics in the public health system, and that acute care in and of itself is not necessarily the most efficient and cost-effective way to deal with pandemics. All right, last line. It's been good spending this semester with you. I hope all goes well in your world, and I appreciate you hanging in there during this very disruptive period and making it through this class. Best of luck.